left atrial appendage. So basically, if you plug the left atrial appendage, you can almost eliminate the risk of stroke in this patient population. So this is why it's really important to eliminate the risk of this left atrial appendage, or you have to anticoagulate your patient. So the left atrial appendage clip is almost the same as the left atrial appendage occluder. Amulet or Watchman or clip can work. The clip works a little bit less because the clip, almost 30% of the clip cases, they have a little bit pouch because you try to stay away from the ostium of the left atrial appendage to minimize the injury to the left circumflex artery, which runs actually across that area. But the clip works, and if your patient has left atrial appendage clip or anticoagulation, you have to identify the reason for the anticoagulation. And if you don't identify anything else besides PE, let's say PE and DVTs or something like that, in that case, you can actually discontinue the anticoagulation and just do aspirin only. And that's similar to the Watchman or Amulet devices that, usually down the road, beyond 6 to 8 weeks, you just try to treat with antiplatelet agent only. So CLIP means that the risk of clots and embolies in atrial fibrillation patients is almost eliminated, so no need for anticoagulation. Is that fair? Any questions about that? All right. I had one of you send me a text messages about a case they had at the facility. Patient has persistent atrial fibrillation on multiple AV nodal blocking agents. I think patient currently not on calcium channel blockers or beta blockers because of hypotension. Patient is on amiodarone, which, as you know, amiodarone is very strong AV nodal blocking agent. And even though your patient in persistent AFib, you can continue to use amiodarone, which is reasonable to be used. The question was about digoxin. I'm not a fan of digoxin. Digoxin really does not work unless you are in acute settings in the ICU. You can give 1.5 milligram of digoxin IV, and you can buy time until the sepsis settles down and stuff like that. But I'm afraid some of these patients that you cannot really control the heart rate, they're gonna end up needing AV nodal ablation and pacemaker. So we can try tricks, but maintaining the heart rate above 110, 120, I'm okay below 110. There's a lenient AFib study which actually tried to see if your average heart rate below 110. The study was done for about 3 years average, and the outcome was the same. So if you take your patient population in the nursing homes, most of them, their average life expectancy is about 3 years or so. So that's reasonable if you can keep the heart rate below 110. But when it becomes above 110, 120, in that case, you have to think about alternatives. Keep in your mind, AV nodal blocking agents such as metoprolol or even verapamil, when you slow the heart rate down, the blood pressure will go up. So it's not a bad idea to try some beta blockers, even though the blood pressure is that low. So increase your midodrine, give them some fludrocortisone, and then start titrate up some good beta blocker, beta 1 selective, such as bisoprolol or metoprolol. Don't use carvedilol or labetalol, or propranolol. So use one of those beta 1 selective agents that the blood pressure effect is going to be much minimized. In my experience, usually most of the time, when you decrease the heart rate, the blood pressure is going to go up. So because the time for filling is going to go longer, and that stroke volume is going to increase and blood pressure is going to go up. So I would try in this patient, I would try to give higher dose of midodrine, start fludrocortisone 0.1 milligram twice a day or even 3 times a day, and try to utilize metoprolol and tell them that to hold if blood pressure below 75, for instance, systolic. Sounds crazy a little bit, but I mean, most of these patients are really not mobile. So you can do trial, and you can try to buy time. So the midodrine 10 milligram BID, number one, midodrine, usually actually TID medication. So if you have to go up on 20, I had patient on 30 TID actually. So if that's going to save your patient, buy you time to prevent the AV nodal ablation pacemaker, so be it. Again, some of these patients are going to end up needing pacemaker and AV nodal ablation, but I would buy some time, increase the midodrine, give it 3 times a day, start some up titrate some beta blockers, see how your patient respond. And I would start visit your patient couple days, see how they do, and then try to play with it. I mean, even the blood pressure is the 80s, 90s. In these sedentary patients, that's no big of a deal. It's not, you're not going to be afraid of standing up and passing out because of that. And any similar to what we say always about the art of medicine, you do intervention and you see how your patient is going to be doing. But again, some of these patients are going to end up needing AV nodal ablation, leadless pacemaker or BiV pacemaker or something like that as a solution for their issues. That is
Tiffany, that was your patient. Do you have anything to add or any other questions?
Sorry, I'm driving. No, that's why I put it in the chat, because he is on 100 milligrams BID of metoprolol already. I'll ask him about his pacemaker thoughts and stuff like that, and consider the hydrocortisone. But yeah, no, we're good.
How about verapamil? Do you think verapamil will work, or cardizem maybe? My experience with these patients, a lot of times actually the AV node will get tired and you all of a sudden actually start being slow, it's going to slow down, and then you probably down titrate these medications. But I would try stuff like that unless your patient is in congestive heart failure exacerbation that is really not manageable. But as long as you have some time, because the heart is very resilient, tachymedia cardiomyopathy is going to take some time actually to happen. So that means maybe 2-3 months, even 4 months actually sometimes. So I would try more AV nodal blocking agents. I would avoid digoxin. Digoxin is just dangerous though. Any deviation in your kidney function, and then this medication, which is very long half-life, 28 to 34 hours, is going to stick around in your body and it's going to be really very difficult. And it's not nowadays, digoxin toxicity is not forgiving anymore because there's a lot of data. There's always can be actually you are kind of accused of being neglecting your patient, especially if your kidney function is not going the right way, and if you're hypokalemia, as you know, hypokalemia exacerbates digoxin toxicity. A lot of points that you have to be careful about, especially in circumstances such as the nursing homes, where sometimes you really resources are minimal.
Yeah, thank you. I had ordered an echo, so that should be back, because I am concerned now that because he's been in a heart failure exacerbation for a while, fluid on chest X-ray and stuff. So I did order the echo, and he's been this RVR since I've known him, so which has been almost a year at this point. So
okay, then you may need to use some connections to get him AV node. Just tell them, hey, just can you do leadless pacemaker AV node ablation?
Dr. Ibrahim, I have a question.
Go ahead.
Does verapamil affect the blood pressure that much?
It does.
It does. Okay.
Yeah.
Okay.
But again, the decrease in heart rate may give you better stroke volume, and the blood pressure may not really be affected. It's going to be wash out for the blood pressure.
Okay. Yes.
Any other questions about that?
not about that case, but I don't know if you're going to talk about this next. I've been hearing more now about the leadless pacemakers, and I was just curious at what's that decision for that over your normal.
So leadless pacemakers mainly nowadays are RV pacing. The St. Jude Abbott came up with the dual lead pacemakers that you can actually implant in the RA RV, but they're not really popular yet. But the leadless pacemaker that we use is mainly the Medtronic one, which is the RV single chamber device. So if your patient having sinus pauses every once in a while, which are symptomatic that you don't expect to use RV pacing, but maybe few percentage a day, leadless pacemaker is reasonable. If you have patient with complete heart block, I would not use leadless pacemaker, even though the leadless pacemaker, some of them, the AV device from Medtronic can sense the atrial kick, and based on the opening of the tricuspid valve can actually pace the RV based on that. But the success rate is not good with these devices. So I would use these devices, number one, if you have minimal access. Number two, if you have, which is going to be prohibitive of your patient to have leads in the subclavian veins. Somebody with end-stage kidney disease, for instance, that they need single chamber device. If you have somebody with chronic atrial fibrillation that you really don't care about the RA, what's doing, and the atria, so leadless pacemaker is reasonable. I would use that for sinus pauses that I do expect some need for RV pacing every once in a while, but not very frequent, because it's not going to give you the synchrony that you need if you have dual chamber device. And I would use that for elderly patients that I know that this is the only alternative that they have. So a single chamber device, atrial fibrillation, or pauses that you're not gonna need to sense the atria. In that case, I would use leadless pacemaker. Obviously, less infection rate. Success rate is about 97-98%. Complication rate is less than the regular devices because you're not going to go through the subclavian, so the bleeding risk is going to be much less, and the pneumothorax is going to be much less. Infection is going to be much less. So I'll give you a few examples. 20-plus-year-old lady passing out. We did loop recorder on her. She was having 20-plus-second pauses associated with syncope, fractured couple teeth. So in that case, I did the leadless pacemaker on her. She's gonna go to nursing and all of that. So I give her leadless pacemaker. It's St. Jude. Longevity is about 25 years or so. She's gonna use it maybe once or twice every quarter, every 3 or 4 months. So this case is reasonable. I've done leadless pacemaker in patients who are demented, they are bedridden, they are complete heart block. You're not going to need the atrial synchrony in this case, in these patients. The risk of dual chamber device is going to be a little bit bigger because of the way their hygiene and so forth. So leadless pacemaker in this 90-year-old patient is not unreasonable. I've done it with patient with persistent atrial fibrillation, status post AV nodal ablation. Even though now if the patient is a little bit younger, I try to do BiV pacemaker AV nodal ablation because you can create synchrony with this patient. But if your patient is 88 years old, it's not a bad idea to do leadless pacemaker AV nodal ablation in these patients. And in patients with AFib with slow ventricular response, leadless pacemaker is reasonable as well. So patients like that is reasonable. You can integrate the device. The device is going to be VVIR, which is rate response, only pacing in the RV. Some of them, the VDR or VDIR, the Medtronic ones, as I said, the sensing the right atrium is not very good. Sensing of the P wave is not very good. So even though it's the package insert, as it can sense both chambers and pace in the RV only, but the sensing is not very good. These patients would like to do the leadless pacemaker. Otherwise, the regular pacemaker is reasonable or more reasonable.
And we're actually gonna have the Abbott rep come on and do a grand rounds next week. I know typically we do bi-weekly, but they were available next Wednesday at 4. And he's been with Abbott a long time, so he's gonna be a really great resource. He's gonna talk through all the different types of devices, indications, and maybe even how to like troubleshoot things from your guys' perspective. So next week at 4, we'll do another Zoom.
Any questions, guys?
Is there anything else in the chat?
All right. Thank you very much, everyone.
Thank you.
Thanks, guys.
Thank you.
Yep, and